Hi, my name is Haley Hill, and I will be evaluating the Monospot as a diagnostic test for infectious mononucleosis. I am a DNP student at Montana State University. Some background on infectious mononucleosis. It is described as having a triad of symptoms, including fever, tonsillar pharyngitis, and lymphadenopathy. It was first described in 1889, but wasn't linked to the Epstein-Barr virus until 1920, when a laboratory worker was infected with Epstein-Barr virus, developed the symptoms of mono, and then tested positive on a heterophil antibody test, which we'll talk about in a little bit. So there's some controversy surrounding the monospot. The CDC does not recommend it for diagnosing mono. The monospot, however, is still widely used in general practice. So the purpose of this presentation is to discuss the monospot's efficacy in clinical practice, especially in regards to sensitivity, specificity, cost versus benefit, and recommendations. The monospot is a heterophil antibody test. It is made of red cells or latex agglutination assays made from horse cells. A blood sample is taken from a patient, and it can be made of serum, plasma, or whole blood, and is added to the horse test cells. And then if the sample contains heterophil antibodies, meaning that the patient is Epstein-Barr virus positive, the red cells will clump together and form a positive result. I'll show you an example on this next slide. This is a positive mono cassette. At the bottom is the trough where the sample goes. At the top is the control line, and that second red line is the positive result. This is where the red cells clump together, forming that positive result. A typical presentation of someone with mono, a peak incidence is usually between 15 to 24 years old. They usually have a low-grade fever, complain of tonsillar pharyngitis. They will have lymphadenopathy, usually in the cervical area. They will have fatigue, splenomegaly, hepatomegaly, adenopathy. Usually will have a headache. Occasionally will have palatal petechiae, maculopapular urticarial rash, and they will typically have a recent exposure to someone who has had mono recently, and usually through kissing. That's why mono has the nickname the kissing disease. And an interesting thing about mono is that it has a latent incubation period of 4 to 6 weeks. We'll talk about that a little bit later. Sensitivity and specificity of the monospot. The sensitivity is around 85%, and specificity is nearly 100%. So false negatives are somewhat common, especially during that first 4 to 6 weeks of infection. That first week, there's a 25% chance of a false negative, which is pretty high. And it goes down from there. So 5 to 10% chance of a false negative in the second week, 5% chance in the third week, and it drops from there. The monospot is less sensitive in children than adults, 60% sensitive in children, which take it with a grain of salt because children are less likely to have mono than adults anyway. And false positives are extremely rare, but have been known to occur in cases of rubella, HIV, leukemia, lymphoma, lupus, and pancreatic cancer. The formal guidelines, or the gold standard, if you will, from the CDC is that you get a lymphocyte count of 4,500 to confirm a diagnosis of mono. So the mono spot costs $20 to $30 on average. It takes about 10 minutes and usually just requires a finger stick. To get a lymphocyte count usually requires a CBC to obtain, and that requires a venipuncture. If you have a good phlebotomist, that takes about 15 minutes if you have an in-house lab, which costs about $50 if you don't have to send it out, which could take more time and more money. So you have to weigh those options. Then there's always the question of, is confirming the presence of a virus helpful? Because you can't do anything about it anyway. And that's a valid point, but confirming mono gives the patient a peace of mind. It helps rule out other disease processes. I'm sure there's no cure to mono, but it can help the patient alleviate suffering. So I think it's worthwhile. So after reviewing the literature, the recommendations that I find valid are to not use the Monospot if the patient has been symptomatic for less than a week, or if the patient is less than 12 years old, because you have a significantly higher chance of a false negative. So you'll have to end up confirming the result with the CBC anyway. So you might as well just start with the CBC. I think the Monospot is a very valid option if the patient has been symptomatic for greater than a week, if the patient is greater than 12 years old, and if the patient objects to the venipuncture. I think it's a great option. In summary, I found that the controversy surrounding the Monospot was less about the research and more about patient consideration. I feel like you should rely on the differential diagnostic techniques and laboratory testing available. By doing so, you're able to eliminate other disease processes. I hope that you will be able to be aware of the sensitivity and specificity limitations of the Monospot, that you are aware of the gold standard set by the CDC, and that you are able to present the facts and the options available to the patient and help them make the best informed decision for their care.